Good morning, everyone. I am Dr. Anshuman Mishra, Head Department of Anesthesia and Pain Medicine at Yatharth Super Speciality Hospital, Greater Noida. Today, I will be speaking on a very important topic, pericardial effusion and cardiac tamponade. I would like to thank AORA for giving me the opportunity to present on this difficult topic and also giving us the opportunity to have a AORA fellow from this session, July onwards. At the outset, I have few declaration. Videos in this presentation are from web as these are emergency conditions and need immediate intervention. So it is very tricky to capture any pictures or videos lot many times. The first question that comes to your mind when we are studying doing a cardiac POCUS. Why do you need to understand about pericardium and pericardial effusion and in fact cardiac tamponade? In an era where we're obsessed with ejection fraction, the contractility of the heart, diastolic dysfunction, valvular function, even inferior vena cava, does pericardial effusion have any role at all? And we, in the next 15 minutes, will be trying to enumerate the advantages, disadvantages, and the need of the same. This is a 17-year-old patient presented to ER following a road traffic accident. There he developed hemodynamic instability leading to near arrest. The echo was done which revealed rapidly progressing pericardial effusion and pericardiocentesis was done, but there was no improvement. So decision for thoracotomy was done and the patient, as the patient had the rent in the right atrium, which was repaired, he is now recovering. So pericardial tamponade is a reversible cause of cardiac arrest and echocardiography is the gold standard for the diagnosis of pericardial effusion. In fact, the European Society of Cardiology also recommends it as a level 1C for the role of echocardiography in diagnosis of pericardial effusion. And American Heart Association makes it mandatory to find out the reversible causes of cardiac arrest like pericardial tamponade so that life can be saved. Does it really improve the time clinically? Yes. It improves the time to pericardiocentesis for clinically significant effusion. And this in an emergency department if there is an user point of care ultrasonography. And this was published in 2017, which put into rest this doubt whether it does really benefit in any of the conditions. Few words about the pericardium. Now, as you can see, pericardium is a double-layered membrane that encircles the heart and the few centimeters of both outer and pulmonary arteries. It has got two layers. So, one is an outer fibrous layer and inner serous, which has the outer parietal and inner visceral epicardium. The physiological pericardial fluid is less than 50 ml. So, if you see this picture, so this is how the pericardium and pericardial fluids look. So this is the pericardium and this is the descending thoracic artery and this is the left and this is the right ventricle. Now, when we see a when we think about cardiac conditions, we see a image. If we see an image like this, it's very colorful, which has a left ventricle, left arterial, we have mitral valve, we have a right ventricular outflow tract, we have an aortic valve, but life is not so colorful. So what we get is different shades of gray, and we have to diagnose and do the interventions in these patients only, in this image, this view only. To start with, normal pericardial fluid, as we all discussed now, it is less than 50 ml. It's usually between 10 to 50 ml. The sole purpose is for lubrication, and it is only during systole that if pericardial fluid is visible. It's not if it's very difficult to see a pericardial fluid during systole. But again, we'll discuss why pericardial effusion is important. So this appears as echo-free space between two layers of the pericardium. The presence, if it exceeds the volume of 50 ml, then we consider it as an effusion. It is a posterior collection or a dependent collection or a circumferential spread because it is a liquid. Any POCUS examination has to be done in IAM protocol For I is an indication, A stands for the aim of the thing, and aim and acquisition of the images. I is interpretation of these images, and M is the medical decision making. What are the indications? The indications is to rule out pericardial effusion as cause of undiagnosed hypotension or shock, unexplained dyspnea and chest pain. So, undiagnosed hypotension and shock is a reversible cause which can be diagnosed instantly and treated instantly if the cause is cardiac tamponade. So, it is pertinent that we do a good scan of the pericardial effusion, find out the pericardial effusion and tamponade, and do the necessary intervention. Now, next point is image acquisition. So we did the interpretation, why the indication of this. Now we go for the aim, which is image acquisition basically. That will be the image acquisition. First image that we will be doing is that we go for a subcostal view. So we use a curvilinear probe, and if you can see, this is the heart and this is the pericardial effusion around this. Now, we use a curvilinear probe. The advantages of curvilinear probe uses is that we can use the curvilinear probe, same probe, for getting a subcostal view of the thoracic cavity. And then if there is no issue of the cause of hypertension, then we can again with the same probe come down to the abdominal cavity and do an E-fast. So that saves us time for changing of probes. This is easy to acquire, and it measures the pericardial effusion if it is present or not. The second image that we're interested is in a parasternal long axis view. So if you can see, this is the heart and this is the pericardial effusion that is happening, and this is the descending thoracic aorta. Now, it is used with a phased array probe. It is technically challenging as we need to insulate the ultrasound rays between the ribs so that it transects the heart in a long axis, and it gives us a long axis view of the heart. The advantage of this image is that it distinguishes between the pericardial and pleural effusion. Pleural effusion is one of the differential diagnoses of pericardial effusion. The third image that we get is a parasternal short axis. So we already did a parasternal long axis. This is a parasternal short axis view. So what we see is that this one, in the diastole, the right ventricle is collapsing. Why it is important, I will explain as we move further. The fourth important image that we get, which will complete the imaging, is the apical fourth chamber. So here you see, in the apical fourth chamber, you see there is a septal bounce due to ventricular interdependence. And there is RA systolic and RV diastolic collapse. Now, let me explain it to you why RA systolic and RA diastolic are important. So, in an RA, what do we do is that when we get an RA, in an RA, when the heart is contracting, in a systole, the heart is completely contracted. Now, there is a potential space between the epicardium and the pericardium. So, if the initial stages, what happens if there is a pleural pericardial effusion, the effusion will collect and it will press on the thinnest wall of the heart, and that is the right atrium. So, collapse of the right atrium at systole is the earliest sign of pericardial effusion. But as the heart fills up in diastole, we do not expect any space to be between the epicardium and the pericardium. But when we see there is some collection, and that is leading to diastolic collapse of the right ventricle, that means the pericardial effusion is definitely present. When we get a pericardial effusion, we need to first find out whether it is pericardial effusion or it is due to some other causes like epicardial fat. It could be due to pleural effusion or due to localized pericardial effusion. Our need is just to identify a true tamponade leading to hemodynamic consequences which we can intervene and stabilize. So how to differentiate between pericardial effusion and epicardial fat? The pericardial effusion, as you know, is built up of fluid in the pericardial sac. But epicardial fat is the fat in and around the pericardial sac. So as it is in fat, it is attached to the surface of the heart. It is present anteriorly, especially around the right ventricle, and it is non-circumferential, and it moves in sync with the heart, with the heart rhythm, contractility of the heart. Whereas pericardial effusion is a liquid, so it is circumferentially or dependent areas, and it is stationary. It doesn't move with the heart movement. When you do an echo in pericardial effusion, we get a echo-free or a hypoechoic image. In epicardial fat, we get an heterogeneous image. Now, this is an example where we can see a heart is contracting. We can see the epicardium, epicardial fat, and the pericardial effusion, all three in this. Now, the how to differentiate between pleural effusion and pericardial effusion, second differential diagnosis. So we should understand that if the effusion, the collection is posterior to the descending thoracic aorta, then it is pleural effusion. If it is collection is anterior to the descending thoracic aorta, the collection is pericardial effusion. This image, this is done in a parasternal long axis view image that we obtain. If we have a pleural effusion, it is prudent to check other dedicated pleural views so that we can finally diagnose that this is a case of pleural effusion and not pericardial effusion. So it is an urgency but not an emergency. So this is an example where we can see this is the descending thoracic aorta, the parasternal long axis view. This is the pericardial effusion which is anterior to the descending thoracic aorta, and this is pleural effusion which is posterior to the descending thoracic aorta. In sometimes what happens is that you get in a patient of cardiac surgery who has undergone a cardiac surgery, you may end up with having some collection localized because there is localized collection, or it could be secondary to some aneurysmal spreads. So in those patients, what we get that we may get some collection like this inside the between the epicardium and pericardium. It's not very clear where exactly it is, and we do not need to do any intervention in these cases. At least pericardiocentesis is not the intervention. Now, once we get an pericardial effusion, we need to quantify the volume of effusion so that the management can be done. So, what do we do there? We take a subcostal view and we do it at the end of diastole, and then we freeze the screen and we do in a 2D mode. We measure the echo-free space between the gap in the echo-free space. So, if you can see, this is the subcostal view and we measure this distance, gap in between the pericardial effusion space, and this will help us in finding which is what. So if the measurement is less than 1 centimeter, it is a small pericardial effusion, so volume will be less than 100 ml. If it is more than 2 centimeter, the volume will be large, so it will be more than 500 ml. If it is 1 to 2 centimeter, size is moderate and the volume will be between 100 to 500 ml. Now, cardiac tamponade, a few lines about cardiac tamponade. So, pericardial effusion is a big entity. It encompasses a lot of conditions with a severity of tamponade going up. So, initial stages when the pericardial effusion starts, we do not have any findings. First finding that we get are the hemodynamic tamponade findings, where the clinical diagnosis is made that includes the Beck's triad like hypotension, distended neck veins, and muffled heart sounds. As the effusion still increases, it leads to echotamponade. This is the condition where we need to do one ultrasonography of the pericardium, find out the echo findings, and do one pericardiocentesis so that we do not end up with a clinically present cardiac tamponade leading to either hypovolemic shock or even cardiac arrest. What is the pathology of this? There is fluid accumulation in the pericardial sac. The pressure in the pericardial space is more than the heart chamber, so there is collapse of the right atrium and right ventricle. The right-sided filling is compromised. That leads to hypertension. Now, if we understand how a cardiac tamponade occurs in place of a pericardial effusion, it all depends on the rate of collection of fluid and the amount of fluid. If we extrapolate into two, one on x-axis, one on y-axis, the pressure and volume, if you see the broken red line, it shows the limit of the pericardial stretch, whereas the dotted red line shows the acute stretch, acute collection, and dotted blue line shows the chronic reaction. So if you can see in an acute condition, even with a small volume, the limit of pericardial stretch is reached and tamponade occurs. But in a chronic condition, it takes much longer to reach the limit and causing a pericardial tamponade. So it all depends on the rate of collection and amount of fluid that is. What are the echo findings? There is an right atrial systolic collapse and right ventricular diastolic collapse as explained. IVC plethora will be there. Mitral valve and tricuspid valve inflow variations during respiratory cycle is present. But the combination of right ventricular collapse, that is in diastole, and IVC dilatation, it has the greatest positive likelihood ratio of having pericardial. Now, how to find out about how you see about right systolic collapse? Right arterial pressure is least. So this is right systolic collapse that is happening. So right arterial pressure is least during ventricular systole, as we explained. Systolic collapse is the earliest sign of a pericardial effusion. Collapse is more than one-third of the cardiac cycle. It could be due to some false positive tests like large pleural effusion, severe dehydration, or false negative due to increased right arterial pressure or pulmonary artery hypertension. The next important point is RV diastolic collapse. So here what we need to do is find out about, this is more specific than right atrium, but we need to confirm the diastole, and that we do when the mitral valve is open. If the mitral valve is open and there is RV collapse is there, that means it is an RV diastolic collapse, and that is a much more stronger confirmatory sign of presence of pericardial effusion. Third option is that IVC plethora. What happens is that here the heart keeps on hitting, moving, but the IVC doesn't move. But this is the most sensitive but less specific finding. It has high negative it has high negative predictive values. There are a lot many false negative cases like hypovolemic condition and false positive like increased right arterial pressure in case of pulmonary artery hypertension. Then comes to the Doppler variation. Doppler variation is mitral and tricuspid valve inflow variations during a respiratory cycle. So what we know as of now is that if we get the normal physiological variation of right ventricle inflow velocity variation is less than 25%. If it becomes double, more than 50%, the tamponade diagnosis is done. Whereas LV inflow velocity variation is less than 10% normally. If it becomes more than double, more than 25%, then tamponade is done. So this is an advanced application. It also shows sign of pulsus paradoxus in tamponade. So here we take an subcostal view, and again we get the four chamber view, and then we check a mitral valve inflow, where at the end of expiration and inspiration, if the difference is more than 25%, we know that this is a tamponade is present. Medical decision is definitely pericardiocentesis. So my take-home message would be, it is a life-saving medical emergency. It is a reversible cause of cardiac arrest, and it is a clinical diagnosis. In fact, echocardiography aids in diagnosis, and as we discussed, the European Society of Cardiologists has approved it as a level 1C for use of echocardiography for diagnosing and treating pericardial effusions and cardiac tamponade, including pericardiocentesis. American Heart Association recommends use of POCUS to rule out reversible cause of cardiac arrest, which could be cardiac tamponade. An early diagnosis and intervention can save a precious life. So it's my request, humble request to all persons who are doing POCUS to be well versed in this art and save life. Thank you so much.